Okay, thank you very much for the organizers to invite me to this fantastic conference and country. So it's really been excellent to be here. Could you imagine that we one day would have some kind of test that could differentiate those who would benefit from a cure intervention and those who would not benefit? That would actually be exactly what a perfect biomarker should be able to do. So let's first look at what is a biomarker. A biomarker is a biological analysis that predicts a clinically relevant outcome. So, what is a clinically relevant outcome? And I tend to ask my patients participating in our cure trials, what do you want to aim from our research? And this guy, I think he put it very clear. I want my disease not to progress and not being transmitted to others when without taking any pills. And he knows about the Mississippi baby and the Boston patient, so he sort of secured himself by saying, and maybe someday I can say that I'm cured. So what is the best measure of no progress and no transmission? That is undetectable viral load. But we also know that the vast majority of patients, when we stop the treatment here, the viral load will rebound typically within a couple of weeks. What we would like to aim by the cure research is to extend this period so you could be longer and longer without any antiretroviral treatment. And I would say the first study in the world who could just show a difference in a controlled setting of a couple of days, or perhaps weeks, would be a major advantage and would really be a landmark study. So what we should aim for in clinical trials will be time to viral rebound. It is difficult to make predictions, and especially about the future. But we can. But there's one thing that we need, and that is that we need a definite outcome, a robust outcome. Otherwise, we would never be able to assess the predictive values of a possible biomarker during an intervention. So this is crucial. If we don't have that outcome, it will be like reading the time by use of a flashlight in the middle of the night on a sundial. So we really need this fixed point. And there is only one fixed point that are relevant to patients, and that are time of treatment with no viral load. So, in order to study any predictive parameter, we need to do treatment interruption trials. So my first conclusion is that whatever we measure, if we should be able to address the predictive value, we need to do treatment interruption trials. And they should be done by very frequent measuring, 2 or 3 times a week. So instantly, people could be put back on treatment if they have a rebound of the viruses. So this is my first conclusion. There's a need for treatment interruption studies. Well, could we perhaps look at the data on already available on study where people have been taken off treatment and seen, are there any predictors that we already know of could be of advantage for such studies? And actually there are 4 studies. ATCG compiled their data, There's an NRS study from France, a Spartak study being headed from UK, and then our own CLEAR study, who looked at could there be potential biomarkers in patients who actually had their treatment stopped. Also, you could, of course, look at biomarkers associated with elite controllers. So they are patients who actually have cured themselves because they have a very favorable immune system, although very load. So these are where you could look for potential biomarkers. The latter group, those who are elite controllers, we don't develop a cure for that group of patients because they have sort of already cured themselves. So there's no need for a cure for them. They can control the virus without any drugs. But there are a lot of factors associated with elite controllers, and I think that can be used as an inspiration catalog when you design your studies and you want to include relevant parameters. And as you can see, I'll not go through all of them, but there are good genes, bad genes in the host. There's a lot of various immunological parameters, and there are also several viral factors that can be taken into account as possible controllers, but about possible parameters. But they have not been studied in patients who are already on treatment. So the first of the 4 trials that I'll walk you through very briefly was presented this year at CROI by ETMAT, and that's a compilation of 5 different ATCG studies where a treatment interruption was implemented. It included 124 patients, and first they looked at the proportion of patients having more than 1 copy. So they used a highly sensitive single copy RNA. And if people rebounded within 4 weeks, 47% had less than 1 copy. Between 5 and 8 weeks, 29% rebound, and above 8 weeks it was only 8% who had more than 1 copy. So this really says that the lower grade of viremia you have, the less risk you have of rebounding. They looked again also at cell-associated RNA, and they also found that the lower amount of cell-associated RNA you harbor, the lower risk it is for you to rebound. When they looked at cell-associated DNA, there was no difference, but as we heard during the seminar on cure preceding this meeting, there could perhaps be some clustering indicating that there are perhaps not homogeneity in this population. The Spartak trial looked at patients being treated during acute infection, and in one of the groups they were treated for 48 weeks after the acute infection, and then the antiretroviral treatment was stopped. They had 47 patients in that group, and 18 immunological and biological parameters were studied in this study. The only thing they found was that at the time they initiated the treatment interruptions, total DNA, but not integrated DNA, was significantly associated with the time to rebound. They also looked at parameters at the time of ART initiation, also during the acute infection, and found several immunological markers, among others some exhaustion parameters, but they were not statistically significant at the time the treatment interruption was initiated. So what about the French ANRS 116 SALTA study? It was it's going to be published. I don't know if it's published yet, but I had it as a pre-copy. And they actually followed 95 patients that were treated early in the course. It was not acute infections, but it was early in their HIV infection, and they tested 12 variables. What they found was that total DNA at treatment interruption was associated with a reduced rate of rebound. So, and none of the other parameters they studied had any association. In our own study, we treated patients with the HDAC inhibitor panobinostat, and 9 patients stopped treatment in a structured treatment interruption where they had their viral load measured 3 times a week. That was after the panobinostat was given. What we found was there was an association in the drop of total DNA during panobinostat treatment. So what happened, if you measure the drop in total DNA during treatment, there was an association with time to rebound. There was no, association between total DNA at the time we started the panobinostat treatment, indicating that we cannot use these parameters to find out who is going to be in a trial. But it seems that we perhaps can use it to find out whether you should do a treatment interruption or not when you have done your intervention. We also, just out of curiosity, just today we had the paper on the association here with NK cell activity published in Journal of Virology. So what leads that to? Conclusion 2. Predictors of time to rebound are the following: total HIV DNA in CD4 cells, cell-associated RNA, and high sensitive viral load, let's say a single copy assay. I would say that when you should include all patients in clinical intervention trials. If there are no difference in any of these 3, you should not do a structured treatment interruption. If there are any difference in those 3 or any of these 3 parameters, I suggest you have an extension protocol and include a structured treatment interruption in your clinical trial. Otherwise, you, as I said in the beginning, you will never be able to study any other biomarker or the predictive value of any other biomarker. This is probably, these findings are probably a reflection of the reservoir size and idle activity. I think it's important to think about the HIV infection and latent reservoirs as it's not something dead, just there, because a dead cell won't exist in the body. It will be expelled right away. It's like Sleeping Beauty. She's asleep. She cannot replicate, but she still breathes. What about future research? It's for sure that there will be multiple comparisons. The gene arrays, they give you results of 40,000 RNA replications, and if you're going to collate that, that'll be just very, very difficult. So you have to use very advanced statistical analysis to do this. I also think that people will try to put together various parameters that shows an association, and that will need to, if you come up with such an algorithm, it will need to be applied on other data set, or otherwise you will just have cyclization and pat yourself on the shoulder and said, oh, this is so very good. What I did, it has to be tested out on other data sets, it's not being developed upon. I also think that we have heard a lot of associations, but it's very, very difficult to make any clinical decisions based on association of parameters. You need to have an on-off. So you need to be, as a clinician, you need sensitivities, specificities, and positive and negative predictive values. And that's very different from associations that are good when you want to study mechanisms or develop hypotheses. But as a clinician, and you make decisions whether to include a patient in a clinical trial or whether you want to do a structured treatment interruption on a patient's trial, we need definite yes, no, likelihoods. And I would hope you will in the future use the receiver operator characteristics as a way of presenting your results. Last but not least, I think it's very, very important at this stage, very, very early in the cure research time, we'll collect as much material and data as possible from the various studies and then collaborate all over. Thank you very much, and before I end, I would like to thank a couple of persons who have helped me discuss this presentation. First of all, Stephen Deeks from the UCSF, Jonathan Lee from Harvard Medical School, Dan Kuritzkis from Harvard Medical School, Ravina Johnston from Amphar, and my group members in Aarhus. Thank you.